from A&E. So we did a scan, you have got a sequence, and you can ask for the mouse, scroll through it.
Okay, I have
With you.
requested control. Yes. This is a contrast enhanced CT scan in the arterial phase. I'm trying to scroll. Okay. I'm going from up to down. I'm sorry. Yeah. I'll just scroll through all the images before starting to comment. I can see in these sections that there is mild bilateral pleural effusion, right side more than the left side. I'm looking at the liver. The liver appeared normal. There are some prominent small bowel loops uh, in the abdomen. The kidneys appear shrunken in size. That could be normal for the age with some renal cysts. I'm trying to look for any focus of extravasation of contrast because this patient presented with bleed. I am not able to see any. Okay. I can see a small focus of blush of contrast in the, I think this is the cecum, which is matching, the contrast enhancement is matching to the contrast of the arterial vessels. So this is highly suspicious of an arterial bleed. I would scroll through the images to see if there are any other foci of such enhancement. I do not see any other enhancement. There are a few diverticuli within the sigmoid colon. There is also associated mild free fluid within the pelvis and a Foley's bulb within the urinary bladder. I will just go up once again.
Okay, so you have picked up a finding. What would you like to now? You will conclude, or you would like to see something else?
The patient presented with hematemesis. I'm sorry, I didn't get
Yes,
that.
yes.
So I would also look at the upper esophageal, lower esophageal sections if they are seen in the scan. I would like to go up
Uh,
to.
and also Melina, actually, I did not tell you, but Melina was there also.
Okay, okay. So, because of the active blush of contrast within the bubble loop on the right in the right iliac fossa, I would immediately pick up my phone and inform the findings to the referring physician, and I would also inform the interventional radiology team, um, uh, as there is
Okay.
a arterial blush. They would need to intervene as soon as possible.
So you have picked up a finding, which is, this is the finding. Can it be a food residue here?
Yes, it could be. I would also correlate with the venous, portovenous phase and delayed phases to look for increase in any size of the blush. If that's increasing in size, then it would be blush. If it's not, and if it is also present in the plain scan, it would be a food particle.
Okay, thank you. So, so this was acute cecal hemorrhage, as the candidate picked up. I will go through the case, but please remember a key point there. When you do these kinds of CTAs, you must do non-enhanced, and candidate one, you must ask for non-enhanced. Without a non-enhanced, you can do false positive findings. Venous phase, to do venous phase or not, some people do it, some people don't do it. You are right that in venous phase, at times the diagnosis becomes more obvious because contrast can be seen changing position. But Non-enhanced phase is the critical phase. That is the critical phase. So in the exam, you have to immediately ask for non-enhanced phase. Otherwise, you did well. Now, so just to go through the case, there was this arterial blush, which needs confirmation. And so this is the non-enhanced phase. And on non-enhanced phase, you can see that there was nothing there. So this is the critical phase. On a venous phase, which, by the way, we did it because the patient's age, etc., the contrast did change position and it spread right and left. Look at the density, it changed. But the key point in this case is that must ask for non-enhanced phase. Otherwise, you did well. Well done. Next case, please. Now, this case is what happened was that this was brought to the A&E, and the history given was that this is a 73-year-old who had a fall at home about 3 days ago in his lounge, tripped over coffee table, a lot of pain, and patient was, remained immobilized for the last 3 days, got very unwell, and fever, etc. The neighbors actually called the ambulance, and the patient got to the A&E. So they asked for a CT, and this is the CT. 73-year-old. Over to you.
This is the contrast enhanced phase in the soft tissue window of the chest of a 73-year-old patient who suffered a trauma at home. I'm trying to scroll.
You can ask for the mouse again if you cannot.
Okay. Yeah.
Yes, please.
Okay. I'm going to scroll through from up to down if possible. Okay. Yeah. So these are soft tissue sections in the actual sections of contrast enhanced phase. I'm looking from the thorax. I can see that there is bilateral pleural effusion within the pleural spaces with adjacent atelectasis of the lung parenchyma. In the history of trauma, this could also be related to hemothorax. I would, in my routine practice, I would also look for bone windows to see if there is associated rib fractures. Okay, I can see that.
The bone window.
Okay, I will go. I'm sorry for the noise outside.
No
Um,
problem.
I'm trying to scroll. Okay. Actually, I'm not able to scroll well. Okay. I'm looking at the bone sections. From up to down, I can see that there are some osteoarthritic changes which are normal for that age. I do not see any obvious rib fractures. However, in the abdominal section, I could see that there was the liver was going anteriorly through at the edge of the film. I could see that the liver.
I've changed the window if you want. Do you want me to give you the same soft tissue window? I've changed it.
Yes. I will go down again to the abdominal sections to see the finding that I was seeing in the abdomen or regarding the liver. Okay. Actually, I'm not able to scroll well. It just skips the section.
So forget about liver. Don't worry about liver.
Okay. Other than that,
I have given you the bone window again if you want.
okay, I can see that there are some lytic areas within the vertebrae with some soft tissue surrounding the vertebrae. So that could be related to a fracture or metastasis. I would like to also see the sagittal reconstruction to look at the vertebrae in a better way. Can also see that there is some kyphotic deformity, or it could also be positional. I would also confirm this finding on the sagittal reconstruction images of the spine.
Okay, just 1 second, please. I'm moving the mouse myself, so don't move the mouse.
Okay.
Now, what do you think? Which joint is this joint?
It's the costovertebral joint.
Is it normal?
It shows fusion with the vertebra.
And what does that mean?
That means that there is ankylosis happening within the bones, which
Mm-hmm.
could be
So anything
related.
else?
So ankylosis with a kyphotic deformity, it could be a case of ankylosing spondylitis, but I do not see any calcification of the anterior longitudinal ligament.
Mm-hmm.
Or these could be lytic. Especially this vertebra looks like there is lysis involved in that vertebra with adjacent bony fragments.
So what do you think is happening before I show you the sagittal, which you asked for?
I think that there is bony ankylosis with probably a osteoporotic fracture, or this could be also a pathological fracture.
Okay, I have now given you a sagittal. Over to
Okay.
you.
In the sagittal section, I can see that there is diffuse calcification of the anterior longitudinal ligament of the spine with fusion of the dorsal vertebrae. Along with that, I can see that there is vacuum phenomena within one of the lower dorsal vertebrae with
You can move the mouse if you want. You can scroll through. Please continue. You were talking about the vacuum phenomenon.
I can see that there is vacuum phenomena within one of the intervertebral discs. I would like to see if the alignment of that vertebra is normal. In a case of ankylosing spondylitis, such a vacuum phenomena could be a carrot stick fracture of the spine, which could correlate with the symptoms of the patient. So this is an urgent finding, and I would like to inform the
Is there a
referring.
fracture?
Okay, I would take that statement back. This could just be a vacuum phenomenon within the intervertebral disc. I'm trying to look for any fractures in other vertebrae. Can see some fractures within the vertebra just above the vacuum phenomena with some sclerotic areas and some lytic areas within it. I think this is a case of
conclusion. What is your conclusion?
I think this is a case of ankylosing spondylitis with fracture involving one of the dorsal vertebrae, and this needs urgent orthopedic referral.
Where is the fracture in the body of the vertebra? This is what you told me, correct?
Yes, I think
Where is
within
it?
the body.
Where you are pointing out?
Yes, over here also I think this intervertebral disc transection of the anterior longitudinal ligament over here could also mean that there is a carrot stick fracture in ankylosing spondylitis.
Okay, thank you. So this is a case of advanced ankylosing spondylitis with unstable thoracic fracture, bilateral consolidation and pleural effusion. That is just an incidental finding. What I mean is that I have not kept the case because of that. Now, what happens now, the findings of acute or advanced ankylosing spondylitis. So I'm not teaching acute or early ankylosing spondylitis. So what happens is that the syndesmophytes, which is actually the ossification of the annulus fibrosus, that happens. Ankylosis will happen at the annulus fibrosis of the disc, number one. Number two, the facet joints. Number three, the posterior ligaments, the supraspinous ligament, the intraspinous ligament, interspinous ligament, etc., etc. So this gives you this bamboo spine appearance. So this, mechanically speaking, whole of this spine becomes, there is loss of what we call any capability of flexion extension, and it acts like a stick. So even with trivial trauma, there can be fractures. And these fractures is what this case is about. Now, this is another potential exam case where we can see ankylosing or, ankylosis of the SI joints. We can see this sclerosis of the interspinous and the supraspinous ligament. This is known as the dagger sign. This is a case from Radiopedia, where you can see this, the ligamental ossification. You can see ankylosis. This is the dagger sign. And just to make a point that even in cervical spine, look here, just concentrate on the facet joints, and you can see that there is ankylosis of the facet joints. On MR, you can see that once again. And of course, there is calcification of the anterior longitudinal ligament. And look at this advanced case on a T1 weighted sequence. There you can see ossification of the anterior longitudinal ligament, of the disc also, which can happen. And then this is the interspinous ligament, which is completely ossified. Now, the key point to remember is that the fracture will go through the intervertebral disc. That is the key point to remember. And this is also an exam case. This is a plain film. I have shown you a CT scan. And easy to miss on a CT scan unless you know that this is what happens. The fracture goes through. Please remember the history of this patient. It was trivial trauma, and this is classical what will happen. The intervertebral disc is ossified, so the fracture line goes through it. And when it goes through it, then it goes posteriorly. And look at fracture lines in the posterior elements. So this is what we call a three-column fracture, and always look at the posterior elements. And of course, the anterior longitudinal ligament is also, the ossification is lost here. This is not the same case, but this is a similar case, which I have shown you on a CT scan with the same findings. And this is another one from StatDX, where the fracture goes through it, and you have to pick up the posterior element. Key finding is that this is an unstable fracture. And this is what happened with this patient, actually. So let me go through the case. Now, first of all, candidate one, as far as windows are concerned, of course, you asked for a bone window without a lung window. So this is a chest CT. Your lung window should be your second choice window. Look at the, in this case, I was not at all interested, but you have to go through your protocol, what's happening in the lung. And then only then you ask for the bone window. So this patient, look at the history, was a trivial trauma. Patient was living alone at home and became bedbound because of pain, and then was not coming out of the home. The neighbors got worried. They visited, and in the meantime, the patient had developed bilateral, pneumonias. Actually, this was secondary infection, nothing to do with trauma. But why the patient was unable to move was because of this fracture. Now you see this. Candidate did well, where mentioned the vacuum phenomena, which is what it is. But if you look look at this fracture line. It is going posteriorly through the posterior elements. Look here. It is going through the, look here on the other side. So, and otherwise, if you see the costovertebral joints, as I actually asked on the axial also, which can happen in the exam also. Let me go through the costovertebral joints once again. So these are the costovertebral joints, and you can see the ankylosis there. So you have to develop your eyes on this one also, that the costovertebral joints are also involved. So, so candidate one, actually you knew it, but you know, initially you actually gave the correct diagnosis, then you lost confidence. And fracture line, you know, you have to know that the fracture, this is a fracture which goes through the intervertebral disc. Remember it like this, because the intervertebral disc is now a bone, because it is sort of ossified because of longitudinal and posterior longitudinal ligament ossification, annulus fibrous ossification. And then look at the fracture line, it goes posteriorly. Okay, well done.
Yes.
Your next case, please. Just 1 second, I think. There's a problem at my end. Let me reshare it actually. There's a problem. Now you can see a coronal
Yes.
paranasal penis. Okay, candidate one, this is your last case. This is a 73-year-old male, chronic nasal blockage, sinusitis question mark. This is the clinical. Over to you.
Okay, I will just request for remote.
Yeah, please ask. Yes, please.
I'm provided with coronal sections in the bone window of a male who presented with chronic nasal blockage. I'm scrolling anterior to posteriorly. Over here, I can see that there is rarefaction involving the bones, the nasal septum, also the inferior turbinate, with non-visualization of ethmoidal trabeculae and widening of bilateral OMU, with erosions also involving the um, base of the skull. I think even the right clinoid process. It is also involving part of the sphenoid sinus and anterior part of the clivus bone. Just go posteriorly. The vertebrae appear unremarkable. I will just go again anteriorly to look at the abnormality. You can see that there is a lot of erosions and destruction involving the paranasal, the ethmoidal trabeculae, or as well as sphenoid sinus and clivus, with widening of OMU, and there is soft tissue opacification noted within the maxillary sinus, sphenoid sinus, and the bilateral nasal cavity. I think on this, I think there is a soft tissue which is causing all these findings. In my routine practice, I would also look at a soft tissue window to see the extent of the soft tissue. Okay, this is a soft tissue window or coronal section of the same patient. I can see that there is a soft tissue opacification of the nasal cavity. left-sided maxillary sinus extending posteriorly, involving the ethmoid and the sphenoid sinuses and causing erosions of the bone. So I think this is an aggressive process centered in the likely centered within the nasal cavity, just extending into the paranasal sinuses. So this could be a carcinoma involving the nasal mucosa with extension and erosions of the bone. This could also be a chronic polyposis. However, in that case, that would cause a rarefaction and not erosion. Another differential would be I'm going to look at the OMUs again. Okay, I don't think that this is an inverted papilloma. In my routine practice, I would also look at a contrast enhanced sections to look for any contrast enhancement.
Okay. Leave the mouse for me. So I don't have a contrast. What we did was we did an MR. Over to you.
Okay. This is a titulated sequence of the same patient. I'm going to scroll through the images. Okay. Not able to scroll. Yeah. Can see that there is a T2 heterogeneously hypointense soft tissue noted within the nasal cavity and sphenoid sinus with some T1 hyperintense areas that could be sinusitis, reaction sinusitis. Okay. Or yeah, it is causing obliteration of the OMUs and their expansion. I would also want to look at the contrast enhanced images of
Leave it for me, the mouse. Just leave it. I'll give you contrast. Contrast with you. Over to you.
Okay. Trying to look for any contrast enhancement. Yes, it is showing homogeneous contrast enhancement within the soft tissue. There are no areas. Also, there are non-enhancing areas posteriorly. So I think I would keep a differential of nasal mucosal carcinoma with extension and erosions of the paranasal sinuses and anterior part of the clivus. Other differential would again be polyposis.
Polyposis?
Yes.
So you will keep polyposis in differential.
Yes, however, it would be less likely because it is causing a lot of bony destruction, which is
enhance.
Yes, polyposis would show less enhancement than it is enhancing right now. Right, so I would keep a malignancy of the nasal pharyngeal mucosa more than polyposis.
Okay.
In my
You
routine
said
practice,
that it has eroded the clivus. And what about the pituitary fossa?
I will try to look at the pituitary fossa as well. Could I see the sagittal section if
You
possible?
tell me the pituitary fossa on this corona. Where is it?
Okay.
Where is the optic chiasma?
I think the optic chiasma is also involved. So this could be a lesion
Where is
within
the
the,
optic chiasma? Can you point it out to me, please?
yes. Over here.
Mm-hmm.
So it is not involving the optic chiasma.
No, what about the pituitary fossa?
It is involving the pituitary fossa. In fact, the pituitary cannot be seen separately from it.
Okay, thank you. Thank you. Right. In this particular case, actually, your diagnosis is absolutely fine. It was nasal carcinoma, but polyposis was not at all. You see, polyposis, even if you see enhancement, if there is some, in some polyposis, what happens is at times there is trapped fluid inside the polyposis, and at the edge, you might see some enhancement, which is normal mucosa. Otherwise, there is no concept of polyposis enhancing like a solid mass. So you
Right.
should be confident in calling it a nasal carcinoma, what it was. It was malignant by any. Let me go through the anatomy for uh, everybody once again. So what I'll do is I'll go through a normal scan first. Candidate one, you have done well, and you can now switch off because even if I want to give any comments on your scan, I will give it later on, but you can relax. You have done well. Well done. Now, let's go through a normal scan, and then I will show you the abnormal scan. This is just for revision. So the coronal section is the best section, best first section for paranasal sinus. And CT scan is better as the first modality than MR. So these are the two frontal sinuses, and this is the nasal cavity. Now let's concentrate on the nasal cavity. So this is the nasal septum, and this is the where the action is. This is the osteomeatal complex on the right side, osteomeatal complex on the left side. Candidate one was using the word osteomeatal unit, which is fine, whatever word you want to say. Now, this is the maxillary sinus, and this is the uncinate process, and this is the maxillary ostium, and this drains into the middle meatus, which is this part. So this is the middle turbinate, this is the inferior turbinate, and this is the nasal septum. Key point in this case, the case which I showed you, I mean to say, is a bit of a global anatomy than this anatomy, because the finding was gross, it was all obliteration. Now, key point for you, you think like this, when you are looking at a paranasal sinus, I'm not talking about the fine touch, I'm talking about the surrounding neighbors. So this is the orbit, this is the orbit. Please remember that the ethmoid sinus, which is this one, actually is the neighbor of the orbit. And so these are the ethmoid sinuses. As I am going back, you can see the orbit. Just concentrate on orbit, and you can see it attenuates because that is the orbital apex. Now, as we go back, so still ethmoid sinus is there, orbit is there. Going back, orbit is finishing, and then we go into the sphenoid sinus. So we come back, this is the orbit is finishing. This is the pterygopalatine fossa, but I'm not going into details of that. Now, this is the sphenoid sinus. And as we go back, these were the clinoids. This is the posterior clinoid, anterior clinoid. So the pituitary fossa will be here. Now, if you go to a sagittal, which of course I did not show you, but just to make a point, that this is the sphenoid sinus, and this is the clivus, this is the pituitary gland. And just to orient on an axial, just look at the ethmoid sinus and look at the orbits. So these are the orbit. This is the ethmoid sinus, and posterior to that is the sphenoid sinus. As we comes as I go inferiorly, this is the clivus. I'm coming superiorly, sphenoid sinus, And then this is the pituitary fossa, the posterior clinoid and the anterior clinoid, and this is the optic foramen. So with this revision of the global anatomy, we go back to our case. So initially, paranasal sinuses CTs are looked at, in bone window. You do a bone algorithm. So the candidate did well, where she picked up the bony destruction, and then also asked for a soft tissue window. But in any case, let's go back of what is happening. So there is a soft tissue here, and this is the lamina praepatia, which is the wall of the lateral wall of the ethmoid sinus, which is the neighbor of the orbit. You can see there is a bit of mass effect. It is sort of indented, deviated to the outer side, and you can see this mass effect. Here, on the other hand, you can see there must be, so this is the crista galli, and superiorly here, you can see that there is a bit of erosion. So this is, by definition, the perpendicular, the cribriform plate of the ethmoid bone, and that is eroded. So you can imagine that the tumor at least has eroded the anterior cranial fossa. It must be, abutting or whatever the meninges. So as I'm going back, you can see orbit here, orbit here. You can see complete loss of bone. So it is eroded. We are going back. So this is the orbital apex. Now, sphenoid sinus. So this thing should have been full of air, and it is not full of air. It is full of the tumor, and it is causing erosion. Here, there is erosion. Now, somewhere here, this is the anterior clinoid process. So this is the pituitary fossa. And if I change the window, even on a CT scan, it will be better. So this is the anterior clinoid. And as I'm going back, this is the posterior clinoid. So this is the pituitary fossa. And actually the tumor is, even on this CT scan, it looks like it is gone and eroded into the fossa. Of course, I was asking the optic chiasma as a landmark on the MR, but so it looks very aggressive. Now, the points to learn on this, because I can simply start the VIVA from this MRI instead of CT scan. So here the learning points are that when there is trapped fluid or mucous membrane, the signal intensity on a T2 weighted sequence is like water. So this is, the mucous thickening in the frontal sinus. This is in the left side. Look here what is happening in the maxillary sinus. But the tumor itself is intermediate in signal intensity on T2. So this is not fluid. This is different. And within that, you will see trapped fluid. So here, there is a bit of trapped fluid. And as we go back now, as we are going, so this is the orbital apex. Let's do the same anatomy which we did on the CT scan. So this is the orbit. This is the orbit. Anteriorly, the tumor is extending quite anterior. Now you can see it is eroding the septum. This is where it is indenting the lateral wall, which is bended into the orbit on right side. Here on a CT scan, we saw erosion of the cribriform plate. And then as we are going back, the tumor is here. It is completely filling up the sphenoid sinus. Now here you can see these landmarks, which are the internal carotid artery. Actually, you can see the Meckel's cave here and the Meckel's cave here. And this is the internal carotid artery within, the cavernous portion. And this is the supraclinoid internal carotid artery. And you can see now that this is the pituitary fossa. And the tumor is completely sitting in the pituitary fossa. Please remember, this kind of VIVA happens in the exam. And got examples where on a T2 weighted sequence, whole of the VIVA is there. And the things which I'm telling you, exactly that can happen with you. What is what? What is what? What is what? The fine touch of it. And this is the what we call, the we were talking about the optic chiasma. And of course, this is the MCA, and this is the MCA. So even here, you can see that you can do the fine touch of it where the tumor is going. Now, we go to the post-contrast. And on post-contrast, everything enhances. And we can see this erosion of the bone. Is there some, now if you stretch your imagination, remember, this is the site where there was erosion of the cribriform plate. And you can see this dural enhancement. So the fine touch will be that I'll give you maybe half a mark extra if you tell me that there is, dural enhancement. So at least the dura is involved. The brain might not be, but the dura is involved. So this is the orbital apex. We are going posteriorly. This is that trapped fluid which I was talking about. We are going, and here, this is the optic chiasma. And when I come just one slice anteriorly, I can see the tumor here. Just to show you on a sagittal, which I did not show to the candidate, but we can see that how the sphenoid sinus is completely filled. And look at the pituitary fossa. Even the pituitary gland you cannot see separately. Here is the infundibulum, and this is the floor of the third ventricle. And this is the dural thickening which I was pointing out. You see this dura here. So these are, and this is how trapped fluid will look like. Surrounding enhancement, but there is trapped fluid. You know that the tumor is not going into this sinus. And there are pockets of fluid within the lesion itself. Please remember that nasal carcinoma, nasopharyngeal, not exactly nasal, rather nasopharyngeal carcinoma, particularly presents with indolent clinical signs. So this patient had sinusitis since ever. And the patient thought that this is all sinusitis. There were many visits to the ENT in the past years. Again, they did so there was a tumor sitting within that sinusitis. Okay, candidate one, thank you. Well done.
Thank you, sir.
Now, candidate two, are you with us?
Yes, sir.
Okay, now we have got a patient who has this patient is 77-year-old, presented with headache, and they have said rule out SOL, as in a tumor. Because of time factor, I'm going to go through some of the sequences, and then I will show you the sequence which I want you to comment on. So first of all, if you can tell me which sequence, what is this sequence?
So this is flare sequence.
Right. And so I'm going through it. I'm going to the vertex, and I will now just scroll through it for you. "77-year-old. Till now, what is your impression?
Sir, in the preliminary look, I can see that there are chronic ischemic changes in the periventricular white matter along with diffuse atrophic changes in the
Okay.
cerebral hemispheres.
Okay. So then I am showing you what sequence is this?
So this is DWI.
Okay. What is your impression here?
I don't see any restricting focus in the
Okay,
brain.
fine.
Yes.
I'm showing you, and what is this sequence?
This is SWI, sir.
Okay, let me scroll through it for you.
So, uh,
Any finding?
Um, yeah, I can see um, some of the vessels are showing mild susceptibility. Yes.
You know, mild susceptibility vessels on an SWI, they show it quite normally. So don't overcall it. So don't worry about it. And just to make a point that this is a bit of, calcification of the basal
Classification
ganglia.
is wrong. Yes.
So till now we have seen a flare, we have seen a DWI, we have seen an SWI. Let me show you a T2. So this is a T2.
Okay, sir.
Anything? Anything
Nothing,
new, I mean to say.
I mean, nothing significant.
Okay. So
Yeah.
what is left now? Let me go
Uh,
you. Let me show you a T1. Okay. So this
yes.
is the T1. Over to you. Now you scroll it. Ask for mouse.
Okay, sir, I'm asking for maps. I've requested for the mouse and just
Yeah,
try to scroll.
it is with you.
Yeah. So it's moving very fast. Not able to scroll. Yeah, it's in fact jumping.
Okay. Can you, if you can hold the red bar and try to do it from there,
Okay, sir, I'll
you might
try.
be able to control it better. See,
Yeah,
yeah.
I'm trying to roll it better. Yeah. Okay, so I'm looking at the T1 sagittal images of this patient, and um, so the Salas appears partial, which seems to be just a variant, and there is no obvious herniation of the tonsils. The brainstem, I'm not able to scroll right now.
Hint. I showed you all the sequences for the simple reason that the parenchyma, except for the age-related changes or schemic changes which you picked up, has got nothing else. So hint is I'm not worried about the parenchyma. Over to you.
So I'm not able to scroll. I just tried.
Let me scroll for you. Leave it.
Yeah.
Leave it. I'll
Yes.
scroll.
Okay, sir. I'm not able to see the C2 vertebra properly, the odontoid. Yes, I don't see that clearly. And and the signal also looks a bit hypo for T1 weighted images of the visualized cervical vertebrae. Otherwise, otherwise the orbits look normal to me in this section. And the visualized oral cavity, the base of the tongue, they all look normal. The calvarium also shows mildly altered signal intensity. So I
What?
suspect that, yes, sir.
Yeah, please continue.
So I suspect that there is some bony abnormality because the calvarium also shows diffusely altered signals.
Right. What would you do next?
I'll do. I'll look at the spine also if the whole spine is available. Okay.
Over to you.
So, okay. So on these T1 weighted sagittal sections of the spine, I can see that the signals of the vertebrae are lower as compared to the adjoining intervertebral disc. So I suspect that there is some diffuse marrow infiltrative pathology going on in this patient. So based on the findings, I like to look at rest of the spine as well, but based on the findings, I'll suspect marrow infiltrative pathologies like metastasis or myeloma in the patient. I'd like to get the patient evaluated on these lines.
So you will only diagnose it on a T1 weighted sequence?
No, I like to look at the stir as well. Yeah, on the stir sequences, the vertebrae look uniformly bright. Um,
Right. So what
so,
is your conclusion?
so my conclusion is diffuse marrow infiltrative pathology in this case. And in case if there are diffusion weighted images available of the spine, I like to look at those also in case they are available. But my impression would be marrow infiltrative pathology, like metastasis or myeloma.
Anything else?
Or, or lymphoma, but I don't see much of soft tissue, but can be a lymphoma also in the third differential.
Okay. So this case was multiple myeloma, and there was diffuse abnormal marrow signal. And this is a classical case, which is what we call satisfaction of search. And the key point here is that I intentionally showed you all the brain imaging, which, we were not, the parenchyma did not pick up. Actually, this is what happened in real life also. Exactly, this is what happened. But on a T1 weighted sequence, the findings were picked up. I'll elaborate once again when I go through the diacom. And then we asked for whole spine. But on a T1 weighted sequence, you will see that the findings were quite emphatic. So classical, satisfaction of search, and I'm not showing my slide of how to report an MR brain, but please remember I've shown you many times how to report a CT brain, how to report an MR brain, and base of skull, bones, everything, whatever is visible, you must see it. Now, as far as spine is concerned, look at this case. This is another case of not the one which I am showing you, but another one which is a known case of multiple myeloma. So there was one involvement of one, and there was a follow-up image in which the key thing to remember is that when we do MR of the spine for marrow, the key sequences are T1 and STIR, and this is also for MSK, any other part. So these are the two top sequences. And on a T1 weighted sequence, one has to develop eyes. If you see here, this is a normal patient and this is the patient. Uh, Look at the intervertebral disc, look at the vertebra on a T1 weighted sequence. The candidate correctly pointed out that the normal is that the signal intensity of the intervertebral disc should not be lower than the vertebra. If it is the vertebral signal intensity is lower than the adjacent intervertebral disc, means problem. And similarly, in any other MSK, septic arthritis, bone, infiltrate, tumor, etc., you have to, in that scenario, because you compare it with adjacent muscle. So it should not be lower than the muscle. Then you look at the stir sequence. Please remember, stir sequence, this is a normal stir sequence. Stir sequence, by definition, is a fat saturated sequence. So develop your eyes on this one, because the fatty marrow is saturated, and that is why it looks quite black as compared to this abnormal, which is diffusely high signal. So you have to develop your eyes on this stir sequence, that it should be, this is normal. And another thing, I have not put slides here for myelofibrosis, where on a T1 weighted sequence, it will be, low signal. On stir also, it will be low signal in myelofibrosis or myelosclerosis. And in some of the sclerotic mets, particularly prostatic mets, where they are on a CT scan, they are diffusely high density, it might be low signal on stir, and that is then better diagnosed on bone scan. But that's a different subject. That was not my aim today. So I've just put in few slides here just to show you diffuse marrow abnormality. This is the case of CA lung, where there is diffuse, abnormality. You just pick up, for example, look at this vertebra and see the intervertebral disc, and you will agree that the intervertebral disc is higher in signal as compared to the vertebra. Then look at the stir, and it is higher. And this is a super scan of the same patient where there is diffuse uptake. So super scan per se is an exam case, remember. To Cyrex to go through the case. Now you remember, I'm just, remember on every other sequence, T2, flare, etc., there was nothing else. Now, here, the key finding, if you see the key finding is in the vertebra. So this should be part of your protocol to look at the vertebrae, whichever are visible to you on this sagittal. And now ask yourself, look at this marrow and look at the intervertebral disc. This marrow is lower than the intervertebral disc. And then the candidate did well. Once pick that up, then also, mention that maybe the marrow in the calvarium is also abnormal. It is low signal. Please remember that this is the diploic space. Diploic space, this is the outer table, this is the inner table. This black line is outer table, inner table. This is the diploic space. Diploic space has got fatty marrow. And that is why it is high in signal intensity. You will agree that at places that high signal is gone. When you see low signal in marrow on a T1, please be worried about marrow infiltration. So, and then of course on the spine, it became very obvious. Low signal in the vertebra, and the intervertebral disc is higher in signal. This was the stir. I did not show you the lower spine. But again, same finding there. Here there is a bit of marrow which is still not infiltrated. And this is the stir sequence, and look at this. Okay, so this was a case of diffuse marrow abnormality, and actually it was multiple myeloma. The candidate did well there, and so that is fine. Now, candidate 2.
Yes, sir.
89-year-old female, syncope, loss of consciousness, 4 minutes, 2 episodes, stabbing pain, chest. They have asked for aorta study. Over to you.
Yes. So can I ask for a remote?
Yes, please.
Just trying to scroll.
Just concentrate on aorta, please.
Okay, sir.
I've given you a better window for aorta.
So I'm not able to scroll well. If you can scroll for me.
Yeah, okay. Leave it. Don't move now. So I'll go up to the heart, and
So, so I've been provided with the contrast CT images in the arterial phase.
so
And
candidate 2, I want you to just follow this, which is the ascending aorta, and please keep talking. Over to you.
Okay, sir.
So I'm going down now.
Yes. So in the descending thoracic aorta, I can see some small penetrating ulcers, and then here, yes, on this slice, I can see that there is. Can I see the soft tissue window here, because there's some precentric rim of, yeah, hyperdensity which I can see all around this, and then there is a flap possibly here. Like if you can scroll up and down for me at this point, yes, so this section. If I can take us, yeah, this seems to be a flap, and along with some penetrating ulcers and intramural hematomas. So, and then there is some fluid as well seen in the left pleural cavity. So, I would like to check the attenuation of this. If it's blood, so probably this could be hematoma,
So
because
this was not blood, by the way. This was not blood.
okay, sir.
Keep looking at the aorta. I'm going down towards the abdomen.
Okay. So I can see all those penetrating ulcers. Yes.
Right. I'm coming up once again. Keep looking, and I'm coming up.
Okay. Yeah, at this point, I believe that there is a dissection. I'd like to see this in other planes as well.
Okay, I'll show you other plane, but let's go up. I'm going towards the arch. Keep looking.
Yeah. Sir, yeah. Yeah. Yeah, there is some small contrast pouch which I can see here. Yes, here.
Okay,
Uh, yes.
let me show you a suggestion.
Okay.
So let's go from anterior to posterior. Let me
Yes.
slightly change the location now. So ascending,
Yes, sir.
let me slightly make it bigger for everybody.
Yeah, this point. Um, I'm not able to trace the continuity of this, but definitely there is some contrastful pouch which is possibly in relation to the aorta only.
Right. So what is your general conclusion? Do you want to see anything else?
I like to see the ascending aorta also, the origin of the coronaries
I'm
also.
not worried about descending out.
Okay, so mm, um,
Any other sequence?
um, uh, if I can see plane as well,
Plane.
yeah. No, there's no such hyperdensity. So definitely there is some contrast leak or which is going on, and then there is hyperdensity suggestive of intramural hematoma in the descending thoracic aorta.
Okay, what is
Uh,
your conclusion?
so my conclusion is acute aortic syndrome in this patient, and with this small contrast-filled pouch, which although I'm not able to trace its continuity with the aorta, but definitely um, it is some contrast leak, some aortic leak, which might have happened, and which is possibly communicating, because there is contrast enhancement in this in the arterial phase. So this can be a pseudoaneurysm, or this can be a large penetrating ulcer only here. So
Right. So you
yeah,
have picked up a penetrating ulcer or a pseudoaneurysm, whatever. You
yes, sir.
are you have picked up here. What have
The
you picked up
intramural
here? The
hematoma, the intramural
intramural
hematoma
hematoma,
here.
and
Yes,
you
sir.
have picked up
A lot of atheromatous changes, and yeah,
what is this?
this is a flap.
So what is this? What you will call it?
Dissection.
What is the definition of aortic, acute aortic syndrome? Which pathologies you are looking for?
For dissections,
And
or some ac- penetrating, I think ulcers leading to intramural hematomas are also, they also come in the acute aortic syndrome.
okay, thank you. So this was acute aortic syndrome. Dissection flap was there, which is not written here on this slide, but remember there is a dissection flap and maybe two, uh, slightly controversial, but maybe a developing one. Then atherosclerotic ulcer and intramural hematoma. Now, acute aortic syndrome, what is the definition of acute aortic syndrome? This is all from Radiopedia, by the way. So it is a life-threatening aortic pathology, similar clinical presentations, and sharing epidemiological and clinical presentation, and might have overlapping and sometimes coexisting imaging feature. So one thing can go with the second, and one thing can develop into the second, that kind of a thing. Now, these are the top three things which you must remember in acute aortic syndrome, which is aortic dissection, aortic intramural hematoma, and penetrating it through sclerotic ulcers. Other authors or authorities, they actually include other things like even aortic injuries, a post-trauma or leaking aneurysm or etc., etc. But I think the general consensus is that these three you must have concept about. Look at this epidemiology. So these are elderly patients. Hypertension is smoking, COPD, coronary artery disease. Now, the clinical presentation is important to remember because according to the location, the symptoms will be according to the location. Now, characteristic pain is severe chest pain, which has been described as tearing, absolutely devastating pain. And sometimes it has got migratory character. And the location correlates with the pathology. So anteriorly in chest or in you can have, the patient can have neck or jaw pain. And if the descending aorta is involved, then back and abdomen. Of course, the patient can have, can come with shock and congestive heart failure. And please remember, the symptoms may overlap with those of acute coronary syndrome or pulmonary embolism. So always look at that also. Treatment is, like your dissection, you remember the Stanford classification. Type A is ascending aorta, type B is distal to the subclavian. And the journal consensus is, or the journal concept is, that ascending aorta is considered emergency and usually surgical, while descending, the definition is distal to the subclavian, usually medical treatment. So all of these pathologies are, sort of tackled according to their location. Location is important. I've just put in these beautiful diagrams from Radiopedia, which you can revise from Radiopedia. But three pathologies. Now, aortic dissection. This also tells you the pathogenesis. So I think a beautiful way to radiopedia, and these are absolutely brilliantly made diagrams. Now, if you see here, these are the three layers of the aorta. Intima is the inner layer, and this is the media, and this is the adventitia. And so, how does dissection happen? There will be an entry tear. There will be a tear of the intima, and then, as you know, look here. So this is Sisley, and this is sorry, this is diastole and Sisley. And now uh, the this is the false lumen, this is the intimal tear, and then it can increase, the false lumen can increase, it can go to various arterial branches, and here they have shown that it can even occlude arterial branches, and then there can be a re-entry tear, and which will save the arterial supply into this vessel. This is the brachiocephalic, by the way. So this is a sum up of everything, where this is the entry tear, this is the intimal flap. So you must see the flap, radiologically speaking, to call it a dissection. This is the false lumen. Key point in the exam. So I'm not showing you a dissection case. I think I've shown you dissection cases in the past. Key point which the examiner will ask you, which one is the false lumen, which is the true lumen. And the key point is that true lumen, trace it till the left ventricle, trace it backwards, and you anything which, and please remember the true lumen might be smaller than the false lumen. So trace it back, and then you are very confident that this is the true lumen. Now, the etiology of aortic intramural hematoma. Here the etiology is different. Now, this is the media. There are blood vessels which are coming from the adventitia, by the way. These are very small blood vessels. They supply the media. They are coming from outside. And these blood vessels are known as vasa vasorum. The etiology is, or the concept is, that they rupture. And because they rupture, there is an hematoma, intramural hematoma. And this is how it will enlarge. For this, please remember, always ask a non-enhanced. Non-enhanced is a must. And one of the key things in non-enhanced is that you will see this high density intramural hematoma. And then this is an enlarging intramural hematoma. And then comes penetrating atherosclerotic ulcer. So the pathophysiology is slightly different. The concept is that on the inner surface of the intima, there is atherosclerosis. And here, uh, ulcer develops. This ulcer gradually enlarges. It penetrates the intima, then goes into the media. And here, if you see this diagram, it looks like a mushroom shape. And the concept of all of these conditions is that ultimately these conditions can then develop into further catastrophic complications like leaking and aneurysm and rupture and all those things. So that is why they are taken very seriously. So coming back to the case, let's go through it quickly. Now, this is not a cardiac gated scan. So that is why there is a bit of artifact. And ascending aorta is well seen if you do a gated scan. So this is the ascending aorta, which is normal in this case. Now here we can see, so this is the arch of aorta. The three vessels are born. These are the great vessels: brachiocephalic, left common carotid, subclavian. So we are distal to the subclavian. Here, and as we, sorry, I'm going other way around actually. Now, here, this is the arch, and here is the descending aorta. This is the point of contention. So what is this? This actually is a developing dissection flap. If you see, there is a flap here, and it is developing. And the hypothesis is that it was an ulcer which is now developing into dissection. Now, as we go down, you can see that there is some contrast which goes out. So this is an ulcer, and here this thing must be checked on a non-enhanced. So, of course, on a soft tissue window, it looks slightly high density, but you must check it on a non-enhanced ask in the exam. And this is what they are expecting, that you will ask on a non-enhanced. And on a non-enhanced, you can see this high density crescent. So this is intramural hematoma. Going back here, that there were other ulcers. So this was another ulcer, and more distally, another dissection flap is developed, and then more distally here, just before we go to the abdominal aorta, there is another ulcer here, and another ulcer here actually, and now this is the first artery, which is the celiac artery. So this case has got all three type of pathologies, which is intramural hematoma and ulcer, penetrating ulcer, and dissection flaps, which are not full blown, but they are developed. Okay, well done, candidate. But the only thing I wanted you to remember is that you must ask for a non-enhanced. That is the key thing for intramural hematoma. Candidate 2, are you with us?
Yes, sir.
Over to you. Now, this is an MRCP. So what happened was this is a T2 weighted sequence of an MRCP series. This patient is 73-year-old female. Patient presents with jaundice. Patient has got previous history of cholelithiasis known, and they have asked for this MRCP, and the clinical is cholelithiasis question mark.
Okay, sir. So these are T2 coronal sequences which have been given, probably Truphus, and here I can see that.
Can you ask for the mouse?
Yeah, I'll ask. I'm trying to scroll. Okay. So I can see that the.
I think if you scroll from the top red bar, it might be more. Otherwise, I'll take over.
Yeah, I think that's better, sir.
Okay. Let me then tackle it. Just concentrate on the gallbladder first of all. Look at the.
Okay.
I'm just scrolling the gallbladder for you.
Okay, so in the gallbladder, there are multiple T2 hypointense rounded foci suggestive of gallstones within the gallbladder, and the CBD is also looking prominent along with prominent IHBRs, and at the distal end of the CBD, yeah, I can see some small hypointense area, which is possibly okay. So I can see some T2 hypointense area, in fact, in this. So this could represent a malignancy, but but I would like to see the other sequences also to further establish my findings. I would like to see.
Keep looking. I'm scrolling. I'm going right and left. I'll show you everything. So
The
just
image has got
concentrate on
frozen, I
the
think.
frozen for what? You cannot see the images, you mean to say? Candidate 2, you cannot see the images move. This is what you're telling me? I think we have lost the candidate, isn't it? Candidate 2, maybe we have lost the candidate, has
Yes,
gone.
sir. I'm here.
Okay, you're back. So
Yeah.
please keep looking. So I'm going right and left.
Okay. Yeah. Yeah, I can see some T2 hypointense area, soft tissue, which appears to be soft tissue at the distal end of the CBD near the ampulla, and which is further projecting into the duodenal lumen also. So, besides this, there's cholelithiasis, there's the dilatation of upstream CBD and HBRs. So, these are trophus axial images. Here again, I can see that the CBD and HBRs are dilated, and as we are coming down and tracing the CBD further, uh, yes, here I can see that there's some soft tissue which is there near the ampulla and obstructing the flow and resulting in proximal dilatation.
So what is your conclusion till now?
So still now my conclusion is that this could possibly be a malignancy, a cholangiocarcinoma, or a periampullary CA, which is leading to all these changes. Because I don't see a calculus at the distal end of the CPD.
Now,
But I would like to see the rest of the images also if they're available to me.
okay.
And besides that, in the liver, I don't see any focal lesions, any cholangular abscesses, or any other focal lesion.
Okay, what will you like to do next?
I would like to see the I'd like to see the diffusion weighted images if they are available.
They are not
And
available.
okay, then contrast if they are available.
Not available.
Okay, then um, the
Do you want to see another modality?
another, yeah, I'd like to go for for a CT, then triple phase CT.
Okay, this is a CT.
Okay, so
I'm going
the
up and I'll then scroll down. So I am showing you the
okay, again I can see that the HBRs and CBD are dilated, and as they're coming down, uh, yeah, yeah, there is some soft tissue which is there, which I can see near the ampulla again, and I would also like to see all the phases if they're available, particularly the delayed phase, because cholangio CS they normally enhance in the delayed phase of the images around 15 minutes if they're available, so that they're better delineated.
nothing is available.
Okay. So, okay. And besides that, I would like to look at the nodes also in the adjoining region. If they're
So what is
there,
your
yeah, I can.
conclusion?
Uh, so my conclusion is that it is possibly a periampullary CA, possibly cholangiocarcinoma, which is leading to obstructive ileopathy along with cholelithiasis, and with no obvious metastatic deposits or cholangular abscesses in the liver.
What else can
And
it be?
um, it can be I would also like to see the walls of the duodenum also. Yeah, that is also looking thickened. So, so that would also
So,
come under periampullary CA only.
okay.
Uh,
So your conclusion is periampullary CA or cholangio.
yes, sir. Sir, can I look at the arterial phase? The arterial phase
There
is
is
not
no
available.
arterial phase.
Okay.
Why do you need an arterial phase?
Yes,
Why
so
do
my
you
impression,
need an arterial phase?
um, just to look, I mean, for any carcinoid or like to rule out. So my
Okay.
final diagnosis would be
Yeah.
periampullary CA only in this case. Yes.
Right. Okay. Thank you. This is a duodenal carcinoma.
Okay.
And the key thing is what is the epicenter of the lesion? So this is this is a duodenal carcinoma causing biliary obstruction. So the key thing is the epicenter of the lesion, and that is the thinking process or the thought process which is being checked in this case. Now, if you see here on this T2 weighted sequence, uh, of course, there were gallstones, no signs of acute cholecystitis. Now, the extrahepatic biliary duct is dilated. Now, at this point, we can see this cutoff of the CBD, which is obstructed. One of the key points which you must point out is, is the pancreatic duct dilated or not, which is what we call double duct sign. So it is equivocal in that case, but having said that, it should be mentioned. Now, mass was picked up, mass has been picked up, but look at the epicenter of whatever is happening. Now, if you trace it, this is the stomach, and this is the pyloric canal. Somewhere here will be the D1, and this is the D2. Now, if I trace it up and down, now this is the D3. If we trace it upwards, then you can see what is happening. Here, this is the lumen. So this lumen is, within the D2, but this D2, look at the wall. This is thickened here, fungating type of ulcer, mass. And part of the mass, of course, is invading here. And then on a axial sequence, which is this one, we can see the same thing. Now, the key points is, develop your eyes for anatomy where we are in this region. Take the help of D3. Also take the help of the pancreas itself. So this is the D3, and this is heading towards, here is the D4. We trace it upwards, and now we convince ourselves that all of this is duodenum, which is thickened. This is, by the way, within the lumen of that involved segment. And as we go superiorly, then we go into the D1. So, so this is a stricture, a malignant stricture, and which is, now you can actually see how it invades the CBD and obstruct. Till now, I think the pancreatic duct is just next to it. So that is why double duct sign is not all that emphatic, but very soon it will become. Now, there is, as far as everything which you need to see, you can see it on this phase. There is no need of multiple phases. And the key thing is the art of developing the epicenter. This is what it is, the fine touch. Now, this is the D3. We are coming upwards, and you can see the same thing, that the duodenum has got a stricture, and this thing is in the lumen. The same thing which I showed you on that MR. And on the other hand, head of pancreas is a big landmark in this scenario. So we are here. This is the neck. This is the pancreatic duct. This is the CBD. This is the uncinate process. And as we go here, then you can see this obstruction coming from there. I did not show you a coronal CT, I mean to say, but you can see the same things which we picked up on that MR, which is, this is the D3, this is the tumor, and then this is the CBD, which is obstructed here. So this was a sort of a simple case where the fine touch is what is the epicenter, and in this case we can actually pinpoint the epicenter. So candidate 2, thank you very much.
Okay, sir.
Well done.
Thank you, sir.
Now, candidate 3, are you with us?
Hello? Yes, sir.
Okay, I am going to, madam, this is a long case type of a scenario, but I am going to show you a CT chest, one sequence, a CT abdomen of the same case, one sequence, and then I'm going to show you a brain MR. Okay?
Okay. I'll just
Can you
ask
hear
for
me?
control. Yes, sir. Can you hear me?
Yes, we can hear you. Now I'm going to scroll for you. I want you to just concentrate on the mediastinal window and just concentrate on the mediastinum. I'm going through it. Let me give you the history. This is a 44-year-old female. Patient has presented with night sweats, weight loss, fatigue, fever and chills, and she is also confused. She is also confused. So I'm showing you a CT for the time being.
Okay, so this is a CT scan. That's your CT of the chest. I can see. I would like you to scroll through the whole industry. Can we go back up, please?
Say again. You want to
Oh,
take
yeah.
the books?
Yes, can we go up? Yeah, just here, please. Okay, so I can see there are enlarged
No,
mediastinal
madam,
lymph nodes, right?
do you want to scroll yourself? I'm giving you the
Yeah,
choice.
yes, yes,
Ask for
please.
the mouse. Ask for the mouse.
It's already done.
So over to you. Let's see if you can scroll it.
Okay, I'm trying. Oh, okay. So I can see there is enlarged mediastinal lymph nodes. We can see right hilar lymph nodes and coronal lymph nodes as well. I can also see, looking at the left hilum. Sorry, there's just a bit of a lag. You can see there on enlarged mediastinal lymph nodes. I can't see any other abnormality at the mediastinum. The vessels are normal. Is there a long window available, please?
Keep looking at this window.
Okay, so the upper abdomen is unremarkable.
Okay, so what have you picked up till now?
Yeah, mediastinal lymphadenopathy, the
Okay,
enlarged
just
mediastinal lymph
leave the
node.
mouse, please. Just leave the mouse. So just to make a point that the on lung window, everything was normal. And candidate 3, can I ask you, what do you think is, don't move the mouse, I am moving the mouse. What do you think about this and this? This,
Sorry, I can't see your cursor. Sorry, I can't see the arrow.
madam, I can, because I've got 2 screens and I can see the cursor.
I
No?
can only see my cursor. No, I can only
Madam,
see mine.
you are, excuse me, when I move, you should not move because we are controlling the same mouse. So now leave the mouse for me. Don't touch the mouse. Now I am pointing out. Can you see it?
I cannot. You can only see my cursor. I can't see your arrow.
Right.
See the screen moving. Yeah.
So do you see any upper abdominal lymph nodes? This is my question.
Okay. I think I can see just like left gastric, I think, and right
So what is your conclusion till now?
just lymphadenopathy, per-abdominal and mediastinal lymphadenopathy.
Okay. So now I've got a abdominal part, whole abdomen.
Okay.
I am scrolling for you.
So So this is an axial cluster of an abdominal CT in the portal space. I can see multiple enlarged lymph nodes, aortic cava, left para-aortic, and I think it's seen.
Right. Now, the patient, so what is your conclusion till now?
Yeah, multiple enlarged mediastinal and abdominal lymph nodes.
Right. So we have got a brain MR. Which sequence is this?
Okay. This is flare sequence.
Say again, please.
This is flare sequence.
Flare sequence.
So I can see a high signal at a white matter at the left parietal lobe.
Which parietal?
Can we scroll further down? The left parietal lobe.
Right. Which sequence would you like to see now?
Okay, can I see a T1, please?
So this is T1.
Okay. Okay. Slightly low signal on T1.
What else do you want to see?
Can I see a post contrast?
Right. So this is the post contrast.
Okay, so I can see it shows there is a contrast enhancement, but I can see it's sort of attached. I wanted to make sure it's attached to the dura or not. There's enhancement with surrounding edema. Okay, so my first instinct, I was thought of is there a diffusion image, please? I would like to see.
Diffusion was irrelevant. There was nothing restricting.
Oh, okay. I was thinking of any lymphoma. My first interest would be of a lymphoma, since it does not restrict diffusion, so that makes it less likely. My other for enlarged mediastinal lymph nodes as well and abdominal lymph nodes, I was thinking of TB, but the lung window is clear. Also, I can see like basal cisterns are non-enhancing, at least here. I'm trying to link the whole thing up.
Very good, very good. Well done. Good thought process.
Okay.
So, conclusion, anything else comes to your mind? You have pointed out lymphoma, ruled that out slightly, and TB, you have ruled that out. Anything else?
Yeah. Well, just if you look at everything individually, I would say it could be a primary brain tumor with a surrounding pathogenic edema. However, I cannot link it to the abdominal or mediastinal lymph nodes, to be honest. So,
right. Okay, thank you very much. You did very well. You know, the thought process was good. So let's go through it. Now, this is the greatest mimicker in neuroradiology, Mr. Sarcoidosis or Miss Sarcoidosis, whatever you want to call it. And I'll go through some, features of sarcoidosis, neurosarcoidosis. Sarcoidosis can come in the brain. It can come in the spine. Please remember that. And if you know your theoretical knowledge, only then you will pick it up. So this patient was sarcoidosis with chest and abdominal lymphadenopathy, and in the brain, meningeal and parenchymal lesions, which I will show you, because the candidate was worried about dura, ruled out dura, but there is more to that, which I will tell you. Now, revise your sarcoidosis from Chapman. This is the consolidated in the second half intrathoracic sarcoidosis. And we know that there are 1, 2, 3 stages, and lymphadenopathy is one of the stage. And then as far as what we call the, again in abdomen, you can have lymphadenopathy and other stigmata. As far as neuro is concerned, please remember it can have parenchymal abnormality, brain parenchymal abnormality, as well as single or multiple enhancing masses may also occur. How do they occur? I will tell you. And there can be involvement of the meninges. So if you know the concepts, you can make your radiology. This is what I always say, that you know your anatomy, you know your pathology, you can make your radiology. So as far as spine is concerned, again, it has come in the exam many times in the spine. And this is a key differential diagnosis in the spine chapter, intraspinal masses. Please remember that this is divided into extradural masses, then intradural extramedullary masses, then intramedullary mass, or which means within the parenchyma, and then subchapter of that is the cauda equina lesions. And sarcoidosis comes in all of that. Remember that. So rarely sarcoidosis can involve the bone. Please remember, I've seen cases where they will be in the bone. You remember sarcoidosis you can be shown cases on feet and hands and things like that. Similarly, in rare cases, it can involve any bone. So spinal bones also. Then comes intradural extramedullary mass. So basic concept is that sarcoidosis actually, the most involvement is leptomeninges. And please remember, from the leptomeninges, it will go into the parenchyma. And of course, vice versa, as in dura can also be involved. And in intradural lesions, here you are, enhancing nodules typically in cervical and upper thoracic cord, usually located peripherally. What do you mean peripherally? Because they come from outside inwards. They come from pia mater or the leptomeninges inside. But imaging wise, for you, it will be an intramedullary lesion. And similarly, in cauda equina, which is common sense, you can see sarcoidosis. Just a recap of the meninges. We know that there are dura mater, arachnoid, and pia. So this is dura, which is 2 layers of dura here on this diagram. This white one is arachnoid, and this green one is the pia mater. Pia mater is adherent to the brain. Arachnoid and pia are together known as leptomeninges. Dura and arachnoid together is known as pachymeninges. So these words should be in your vocabulary. Now, this is, I've shown you so many times this differential diagnosis. It's so important for the exam that meningeal enhancement, pachymeninges, which is dura and arachnoid, and please remember, sarcoidosis will be there. Carcinomatosis, infection, sarcoidosis. Always remember sarcoidosis. Here you are. Granulomatous disease, TB, sarcoid, Wegener's, etc., etc., etc. Even last time I showed you a case from this. And then leptomeninges. Again, leptomeninges, granulomatous disease like TB, sarcoid, Wegener's, etc. Now, the concept of VR spaces. What are VR spaces? Virchow-Robin spaces. Now, if you see this diagram from radiographics, this is the arachnoid, this is the pia. When a blood vessel goes into the parenchyma, surrounding that parenchyma is a space, we call it VR space, which is leptomeningeal space, VR space, as in Virchow-Robin space, this number 3. So please remember, the vessel is going into the parenchyma. So look at this vessel. When this vessel goes into the parenchyma, surrounding it is a space which is known as VR space, Virchow-Robin space. Virchow-Robin space, by definition, uh, will be of CSF intensity. It will be fluid intensity. Sometimes Virchow-Robin spaces are prominent, and there are some locations in which they will be more prominent. For example, in the basal ganglia, lenticulostriate arteries, but also cortical arteries in the midbrain, and sometimes they can be so prominent that they will present to you as a mass. So this diagram tells you prominent Virchow-Robin spaces, and do you see that these are related to the lenticulostriate branches of the M1 segment. Now, look at these normal, and when you report MRs, you will see them particularly in old age patients quite usually. Look at these, these small spaces. These are in the basal ganglia. Look at these ones. These are all Virchow-Robin spaces. This one, and sometimes people confuse this type of a thing as a lacunar infarction. It's not lacunar infarction. It is a Virchow-Robin space. Look at this. Look at the cortex. Look carefully here. You see this thing? How the CSF as if is going into the parenchyma. Now, go back to this diagram and think what will happen if there is sarcoidosis which is involving the leptomeninges. So this thing, pia mater, so this number 2, by the way, is subpial space, sub-pia mater space. So the inflammation can go inside the parenchyma. This is how it will travel into the parenchyma. Radiologically speaking, you will pick up an intraparenchymal lesion in the brain as well as in the spine. But there will be a connection, usually a connection with the leptomeninges. Look at this case. Sarcoidosis in the brain, classical sites other than leptomeningeal and parenchymal enhancement is infundibulum. This is the infundibulum. And there is a differential diagnosis of infundibular regions and lesions, and sarcoidosis is one of them. Now, if you look carefully, look at the meninges, the dura is enhancing. Now, what is happening here? There is some sort of enhancement here. If you stretch your imagination, this enhancement is going into the parenchyma. How is it going? Through the VR spaces. And radiologically speaking, you will feel as if there is an intraparenchymal lesion, but the spread is like that. So this is why sarcoidosis is known as the biggest mimicker in neuroradiology. This is spine sarcoidosis. Now, there is a long segment abnormality. This is a T2 weighted sequence. This is a T1 pre-contrast. This is a T1 post-contrast. Now, on T1 post-contrast, you can see there is some enhancement. So from the pia, the lesion has gone into the parenchyma. Look at this one. You see this? This is it. And this is enhancing. So, and look at this one. There is nothing here, and this is enhancing. So it is intradural. It is also intramedullary lesion. So this is another case of sarcoidosis. You can see you will report it as a tumor, by the way. If you report it, oh, I'm worried about a tumor. If you see, there is enhancement here. And this was a sarcoidosis. On this particular example, you cannot discriminate it. But please remember it, that, sarcoidosis can cause this. Look at this picture from StatDX. And then look at this example where there is enhancement, there is nodule sitting in the cerebellum. And, this is that cauda equina lesions. And of course, the differential will be metastasis. But sarcoidosis can cause all of these things. Another example where look at the cauda equina. And they will start from a T2. I've shown you these kinds of cases where you will see jumbled up nerve roots in the cauda equina. Then you will give contrast or say, I want to give contrast. And this is the picture. So other than metastasis, Another, sarcoidosis should be one of the differential. And in a long case, of course, you might see something else which makes up this. This is a case from STAT DX, and in which there is bone sarcoidosis. You see this extradural, and with that there are lesions in the dura also and parenchymal also. So this was a case of sarcoidosis, and let's quickly go through the learning points on the imaging. So candidate 3, I liked your thought process, and that was well done. The only thing is that I see what the mind knows. So this is what it is. Now you know that sarcoidosis can behave like this, and that is the biggest neuro mimicker in neuroradiology. So these were lymph nodes. One fine touch about it is that even if you get a single CT in a long case, just the axial, you see that there are some lymph nodes in the upper abdomen, and then on the axial, there were many lymph nodes in the abdomen. Of course, I did not show you, and there was no need of showing a coronal, but just for your day-to-day practice, please remember, para-aortic lymph nodes are very well seen on a coronal, because this is the aorta, and you will see them extremely well. You see, look at them. This one is going into the mesentery. So para-aortic nodes are beautifully seen on a coronal. Now, if you go back to this, I showed you the flare sequence on which there was edema, looked like, as if there is a metastatic deposit sitting here, which will be just like this. And if you go to this coronal, now the key thing is that now you can stretch your imagination, that it went through these leptomeninges, through the VR spaces into the parenchyma, and it is presenting as a parenchymal nodule. So this was sarcoidosis. I did not show you a sagittal or an axial, but just one second. This is an axial post. So on this axial, now we are next to the meninges, and you can see this enhancement which goes in, and then you lose it. So this was neurosarcoidosis. Okay, candidate 3, are you with us?
Yes, sir, can you hear me?
Okay, so this is an MR of a 16-year-old. The patient has presented with headache. Over to you.
Out of control, please.
You want
So
the
this is yes,
or
okay,
should
fine, you can scroll, I don't mind.
yeah.
So this is an axial T2 of a young patient complaining of a headache. I can see there is a concentric shaped fluid density extraaxial space causing mass effects on the temporal parietal lobes. So there is no history of trauma in this patient, right?
No history of trauma.
Extra. Okay. Okay. So can I see its flare image, please?
Clear.
Yes, please.
Clear. I'm scrolling for you.
Okay. So this extraaxial space follows the CSF on the flare as well as on flare sequences. It's causing mass effects on the main parenchyma. Can't see any parenchymal abnormality. There's no hydrocephalus.
Anything else you would like to see? Have we lost you, madam? Candidate 3? Candidate, yeah, we have lost her. I cannot see her on the system. Okay, so let me ask the chat. Chat is open. It is a question for anybody, everybody. Yeah, you can participate as a group. Anything else you want to see? DWI. So this is the DWI. And I'm going to show you a corona. So this is a corona. Can I ask you the diagnosis now in the chat? Okay. So the diagnosis is that people have said arachnoid cyst. Some people have said arachnoid cyst ruptured. Some people have said arachnoid cyst with chronic. Some people have said chronic subdural hematoma, hygroma, and ruptured arachnoid cyst with subdural hygroma. Okay, so this is a arachnoid cyst. It's a simple arachnoid cyst. Let me go through it. Now, candidate 4, be ready, because I think candidate 3, we have lost her. She has lost the connection. So you are next, so please be ready. Now, if you see here that on a T2-weighted sequence, it looks like a classical biconvex type of a configuration. Looks like a, let's say, a subdural hygroma. Then the key thing is the middle cranial fossa. And here you can see that it is displacing the temporal lobe. And if you go to other sequences, there is nothing much to add. Arachnoid cyst can also present with hemorrhages, etc. It was not like that. This is the flare sequence. It was a simple case. This is not a hygroma. This is an arachnoid cyst. And the key thing is what is happening in the middle cranial fossa. Middle cranial fossa arachnoid cyst per se is a very, very common finding. And you will see a bit of compression of the temporal lobe. And in long-standing or very big cases, there can be, you have to treat them. Now, in this particular case, the question will be, what will you do next? You cannot sit on this for the simple reason that it is very big, and you can see there is a midline shift to the contralateral side. You have to send it to the neurosurgeons, and they will do some treatment. They have got quite a few options which they do. Fenestration of the cyst. At times they do surgeries, but this is a definite surgical case. So I just wanted to show you an unusual case of arachnoid cyst. So in FRCR exam, unusual presentation of a very common condition is one of the, and this is a type of that case. It is an arachnoid cyst, simple as that. Okay, now somebody has asked, it is ruptured? No, it has not ruptured. Candidate 4, are you with us?
I am, Dr. Khan. Hi.
Okay, so over to you. I think candidate 3 lost her because I can still not see. So we'll continue with you now, candidate 4.
Please, thank you.
So this case is a 78-year-old male. According surgical. It is an A&E case. Over to you.
Thank you. Just requesting control, please.
Okay.
Done.
So with you.
Are you okay? Give me 1 second. Yes, scrolling. I'm presented with axial CT slices of the base of the chest, abdomen, and pelvis with contrast in the portal venous phase. I'm just going to scroll through the given set. Apologies, it's just a little bit laggy on my end.
No problem.
I'm just looking for any pneumoperitoneum. I'm quite suspicious about a locule of air just near the anterior abdominal wall, but I'm just going to keep scrolling. In terms of the bowel pattern, I can see air in the rectum. There wasn't any gross small or large bowel dilatation, non-specific bowel gas pattern, but I'm going to carefully trace the bowel from the rectum upwards. There's a loop of small bowel centrally, which shows evidence of pneumointestinalis, probably distal ileum proximal ileum / jejunum, and surrounding fat stranding. And I'm just going to trace that and see if there's any further extension of this. There is uncomplicated but severe diverticular disease in the descending colon and sigmoid colon. I can see evidence of further pneumointestinalis within small bowel loops in the right upper quadrant. I'm just going to carefully review the liver for any portal venous gas. I can see more evidence of pneumoperitoneum, small locules of air adjacent to the superior border of the liver. And in my usual practice, I would change the window to a lung window just to correlate with those areas. Thank you,
This is
Doctor.
a window.
Thank you. The slices are jumping quite quickly, which is why I'm kind of slowing down and speeding up. Apologies.
No problem.
Okay. Can I go back to the soft tissue window, please? I think I'm strongly suspicious of pneumoperitoneum, and pneumointestinalis fairly diffuse, affecting the small bowel. Now I'm just going to go through my usual review areas. There are multiple cysts in the left kidney.
Okay, so that's fine. Review area will not add to anything, but it's a good practice. So,
Okay.
what is your conclusion?
So, in conclusion, there is diffuse, widespread small bowel wall pneumointestinalis and evidence of adjacent fat stranding, as well as subtle pneumoperitoneum. My principal diagnosis at this point is ischemic bowel with perforation.
Patient, by the way, is not that unwell. Okay, look at the large bowel. You diagnose diverticulosis. Are they diverticulosis? That's a hint for you.
Okay.
So let me, at particular places, now look at large bowel, I'll give you two windows, right?
Okay.
So look at the large bowel now. So this, okay, just hold on, please. Just hold on. Just look at the large and small bowel and conclude your case. I've given you a corona.
Yeah. So I'm presented with coronal images of the lower chest and abdomen and pelvis and the portal venous phase. So in conclusion,
you can scroll.
Yeah. Oh,
You
okay.
can scroll.
Yeah.
Just look at the large and small bowel.
Yeah.
And sort of consolidate your findings and then tell me what is happening.
I'd like to revise my initial description of sigmoid diverticulosis. I actually think this might be gas within the sigmoid colon. It's also extending into the splenic flexure as well as the transverse colon.
Can you look on the right hemidiaphragm? What do you think is happening?
There's pneumoperitoneum.
Okay, what is your final conclusion?
The final conclusion is widespread diffuse small and large bowel ischemia with pneumoperitoneum. And my recommendation is a surgical review.
Okay, thank you. Thank you. Please don't move the mouse. I'm going to take over.
Mm-hmm.
Primary nematosis coli or primary nematosis intestinalis. What is this? Now, if you go to your book, Chapman, 7.25, nematosis intestinalis, gas in the bowel wall, best seen on CT. Differential diagnosis depends on the clinical state of the patient. Remember this. Gas in the bowel can be benign, well patient versus life-threatening or unwell. And this is a case which I have shown you is idiopathic. This is known as, in American literature, they call it primary nematosis intestinalis or coli, whatever. Idiopathic is the etiology. Also known as nematosis cystoides intestinalis, usually involves the colon. But I have seen quite a few patients in small bowel, and this is one of them which I showed you. Appears as a cluster of gas-filled intramural cyst. What is the pathology? The pathology is for unknown reasons. That is why we call it idiopathic. There is cluster of air-containing cyst in the wall. Please also remember that this is a differential diagnosis. Take a screenshot of this. This is quite an old reference, 1991. Pneumoperitoneum with peritonitis, pneumoperitoneum without peritonitis. Please remember, in medical school, we teach like this, that treat the patient, not the X-ray. And this is a classical example. You should have clear-cut concepts that pneumoperitoneum can happen without peritonitis for other causes. I'll go through the causes with you. But this is pneumoperitoneum does not mean surgery, or surgical referral. And with peritonitis is perforated viscous, necrotizing enterocolitis, bowel infarction, penetrating abdominal injuries. These are all acute conditions. But look at this. Pneumoperitoneum without peritonitis, thoracic causes. So air can come from up, track down, and go into the retroperitoneum. It can go from there into the mesentery and into the peritoneal cavity. Abdominal causes. Post laparotomy is one, but this is one. Nematosis, cystoides, coli, or intestinalis. This is the one which I was showing you. Jejunal diverticulosis, endoscopy, paracentesis, peritoneal dialysis, bone marrow transplant. Look at these conditions. HSG, remember that. HSG, which is common sense. Look at the female anatomy. Vagina, cervix, endometrial cavity, then the fallopian tube. So anything which comes from downside, so from distally, through the fallopian tube, it will go into the peritoneal cavity. So you have got a patient who had a hysteroscopy, and you did a plain X-ray, and you might find, pneumoperitoneum. So it is an incidental finding. Pelvic examinations, postmortem, sexual intercourse, vaginal douching, etc., etc. So this is a key concept for you to remember. Look at this. This is exam case, by the way. This, you have to, what I always say, develop your eyes. The eye see what the mind knows. If you know how a cluster of intramural cysts look like, you will only pick it up, otherwise you will not. This is in the sigmoid colon, where there is bunch of grape-like appearance, cluster of cyst. And interestingly, this is from American College of Radiology. And there is a barium enema, which tells you everything. Why? On the barium enema, look at these cysts and look how on profile, some of them as if are bulging outwards. Look at this. So this is nematosis intestinalis. Now this case, and interestingly in our hospital, we have got one patient. I have got about 5-6 scans of this patient with me over the years, and they will present to you with vague symptoms, usually not very severe symptoms, and you will see this. Now, in this particular case, so one feedback is that when you are going through a case, silence should not be there. It's absolutely fine to say that I am going through my protocol or whatever, but in the beginning, there was too long a silence, number one. Number two, whenever you diagnose gas outside or in the lumen, ask for the lung window, and this is what you are going to do in your day-to-day practice also. So don't wait till the end. Some people use the bone window also for picking that up. I use the lung window, which is this one. Now, in this case, there is pneumoperitoneum, but if you see here, there are, all of these are cysts. All of these are cysts where I'm pointing out. These are the small bowel. And similarly in large bowel, these are the air-containing cyst. Let me, because of time factor, just show you from the coronal. Now, you can see These are those air bubbles. And then you did pick up some of them. For example, I think this is one you picked up on axial, but everything else, you can convince yourself going up and down that these are in the wall, changing windows and things like that. So it's a good case where the findings are very, very emphatic. Look here, all of this. And the barium which I showed you, remember how it was. So it's a beautiful case and go all the way here, and you can see all of these cysts, and then this is incidental loma. This air is incidental. So some of the cysts, the concept is that they have burst, they are outside, and simply there is pneumatosis without any peritonitis. Okay, candidate 4.
Yes, sir.
Paranasal sinuses. The history is that this patient is 47-year-old, known chronic sinusitis, now has presented acutely with acute headache, fever, diplopia, orbital pain on the right side. Over to you.
Thank you. I'm presented with coronal CT images of the facial bone, non-contrast. Within the right maxillary sinus, there is near total opacification.
Have you got the mouse? You want the mouse?
Oh, yes, please. Yes, please. I'll just request control
Ask
now.
for it.
Thank you. There is see if I can scroll. I'll just scroll through the images in the set. There is near total opacification of and expansion of the right maxillary sinus with extension and dilatation into the sinus ostium and dilatation of the ostium, as well as opacification of the right nasal and sphenoid sinuses. There is further but reduced opacification in the probably mucosal lining thickening of the left sphenoid sinus and partial opacification of the left nasal sinuses. On bony review, I'm concerned that when compared to the left side, there is cortical involvement and I would say bony destruction, predominantly within the medial maxillary wall.
Where is the medial maxillary wall? What are you saying?
Yep.
Point it out.
Here, I cannot see a clear boundary when compared to here. Sorry, I'll just slow down my mouse here.
I am not interested in this area. Please
Okay.
concentrate on the clinical right orbit.
Right orbit. Yeah.
The patient has got acute symptoms, fever, headache, diplopia, orbital pain on right side. So I've changed the window to soft tissue window.
Thank you. There is the upper lateral margin within the right orbit. There is a soft tissue density with surrounding stranding, which is suspicious for an inflammatory process at this point. When I was reviewing the bone window, I didn't see involvement of the bone.
So look at the bone.
Yes, please.
Okay, so what is your impression till now?
So a summary of my findings are upper lateral area of the right orbit. There is a soft tissue density mass with surrounding fat stranding, as well as opacification and expansion of the right maxillary sinus, and further opacification noted within the sphenoid and nasal sinuses, as I mentioned earlier. At this point, I'm thinking of an inflammatory process, possibly an infection.
What will you do next?
I'd like to do an MRI, please, and actually possibly a contrast CT as well. I'll go with an MRI first.
Okay, leave the mouse. Over to you.
Thank you. So T2 coronal sequences of the same patient with diplopia. I'm carefully reviewing the intraocular muscles for any asymmetry when compared to the left side. Once more, I note the T2 hyperintense signal in the maxillary sinus, which looks cystic in nature, and a central low to intermediate intensity. I'll just concentrate in the right orbit now. When compared to the left, the signal overall is fairly heterogeneous, and